Hello everyone, this is Dr. Khan, Michigan. So this is basically a patient where I've done a complete end block, 72623 initials TK. I cut a small amount of the excess skin. She had what was a grade 4 contracture. As you can see, look how hard and round. This is a lady in her 50s, and she has had implants for 25 years now. Very hard and round, very basically plastered, super glued, frozen. So grade 4 contracture, if you look over here, means that she had breast is hard and painful. The painful part is what makes grade 4 a grade 4 versus grade 3. And it looks abnormal, and the implant is certainly very much visible from a distance because of how hard the capsule has become around. So as you will see, what I'm going to do next is I'm going to go ahead and open this up. And these are sealing implants as per patient. So what I'm going to do is I'm going to go in from this side. This is how the implant was sitting. So there is some tissue here, and let's see what it shows. Again, end block, the gold standard. Blood loss was less than 3 cc's on each side, so I was very happy. This was a very involved dissection. You can see this is a lot of inflammation. If I touch it, it's abnormal tissue, and this was sitting against the chest. So the fascia of the pectoralis major is incorporated in this. So as I go in, let me go ahead and find a nice entry point. As you can see, this is all contained. This is what we want. We want to remove all of this inflamed tissue. Let me actually go in from this side. So very tricky surgery in the sense that it was literally super glued to the pressed. It was on top of the muscle. So no implants are safe. These are supposed to be the saline implants, the safer ones. These should have been banned back in the day when the saline were allowed and the silicone was banned. So as I go in, I don't want to hurt the implant. Very tight. So as I go in, I'm actually going to go in from here. Implants are not safe no matter what. A lot of inflammation, as you can imagine, given the grade 4 painful contracture she had. She researched me for many years before she committed to coming. She and I talked. She's not going to get drains. I have not put in drains in any of my saline patients. So there's some substance to this one, so I'm going to hold this. You can imagine how hard this is. Let me go in from here. So this is a little bit softer. You can see the calcification on the inside. Actually, let me find a nice entry point right here. So you can see this indentation. I want to take advantage of this right here. So very painful as per patient. No one should have to live through this pain. All implants, be it saline or silicone, are bad. They're equally bad. Saline gives you the notion they're more innocent, but they're absolutely not. So I'm going to go in from here. Again, I do not want to hurt the implant, so that's the reason for the goal is to go super slow. And again, you can imagine the calcifications she has. Let me go in. So this has what appears to be a texture type consistency. That's why it's so hard. Let me go and actually It's literally super glued. If you can imagine, super glued to this implant. Here, let's see if we get lucky here. Whatever length of time it takes, I'm going to go ahead and tease this off. Hopefully this will open this up somewhat. You can see all of this tissue is very much inflamed. It's all calcified right here, by the way. That's the reason why I cannot access. So hard. Let me go in from here. Poor lady, she had to live with this for such a long time with all the pain and misery. You can see again, this is very hard. So I'm going to find another. Let me go back to this area here. I do not want to hurt the implant. So I'm going to go ahead and go in from here. There we go. So this is indeed textured. So you can see how super tight it is. And remember, the goal is to go super slow without hurting. You can imagine how tight this is. Literally super glued. So this will certainly... These are nice, good scissors. They go in bluntly. I can dissect without hurting the implant. So what I'm going to do next is I'm going to actually peel this out. The best thing to do is look at this hardness. I'm actually going to go here now. You can actually hear, look. She's like literally living with 2 rocks on her chest. Let's go here. This is intact saline implant. Remember, this is the area where I was trying to get to at. Very hard. Let me go in from here. And so now you can see I wish the FDA is watching this. Look how many, capsular contracture occurs more often than not. And patients, unfortunately, are living with it for years and years. The young and the old. Sometimes it occurs within the first few weeks and months, or sometimes it just all of a sudden occurs from nowhere. But you can see, look at this, hard. This is an intact implant. Now certainly look at these calcifications that are there. I'm going to go away. There's some fluid here. Very hard all the way around. Look at this. This is like the scales of a fish. This can cut into the implant. You can imagine why I was having difficulty going in. So on the other side is the valve. So I don't want to go here. You can see right here. I'm actually going to cut this off. This will help. You can see this is the valve that's closed. All contained, done en bloc, the gold standard. No other better way of doing this than the en bloc fashion. And look at this. If I hold it, You can hear the snaps. Look at this. If I hold it out like this, and look at, if I pass this on the back of my hand, look at all these calcifications. So all of this is going to go to pathology. What's interesting is this implant did not rupture, or I guess not yet. Look at the snap again. So we've seen this many times. I removed some abnormal tissue, so I'm going to send along with this. Look at this implant. It's overinflated, and it's basically your McGann 195. Now the other thing I want to show you here is, look at this. Look at this fluid. You know, I want to say this to the biochemists, to Dr. Henry Dyckman, whoever. See this fluid right here? This is the badness. You just look at this fluid and you will see this is all leaching into the body, causing the havoc, causing all the inflammation. So grade 4 contracture, look, it's retaining its shape. It's like a shell, very tightly adherent to the implant. In the meantime, you can go ahead and look at the capsular contracture. So grade 1, there are 4 grades, also called Baker's classification of capsular contracture. Grade 1 is the normal, that's what we desire. The breast is soft and normal. Its implant is not palpable. Grade 2, breast is firm, looks normal. Grade 3, the breast is hard, firm, and looks abnormal, but it's not painful. And grade 4, you have pain added to what is grade 3 essentially. And so this is where the patient was in the hurt. She had hard, painful breasts that were visible from a distance, and this is certainly the nature of her capsule, as you can see right here. Now all hard tissue was removed, all the inflammation around. Now this is a little bit softer, and I removed this. This is how it was sitting against the chest. So what I'm going to do is, you can see some areas so thin. I'm actually going to go in from here. I feel I will have a good access point. So end block, the gold standard. We're going to send the capsule off to pathology. Take cultures for aerobic, anaerobic, and fungal to make sure there is no infection. Till it's sent out, we won't know. The implant certainly can harbor that. There is biofilm around. Let me go in from here. Again, the goal is to go super slow. You can imagine how easy it is to hurt the implant. You want to make sure your surgeon removes the implant intact. How many patients I know have already gone to a surgeon where they deflated the implant, which is an absolute no-no. You never know what's on the inside, so we don't want that to spill into the chest, hence the purpose behind end block. So as I go in here, let me go in. So this is an intact saline implant, certainly very much textured. You can see the textured nature, just like on the right. Again, the goal is to be very patient, not to puncture or go into it. We'll get to it just like we did on the other side. So let me go in from here. Again, this is super glued. The capsule is scissors are bending. There we go. So I want to show you The textured nature of the implant actually holds the implant nice and tight. So I'm going to show you something. This is how the surgeons do it. Let's say someone has a textured implant and she's going to get a replacement. So the surgeons cut into this. They certainly very much ruptured the implant whenever they're doing a replacement. And then what they do is, in order to free up the implant, they literally put their finger in. And look at this. All of this done en bloc, the gold standard. This is where I have said many times, 20 years from now, I cannot imagine anyone else doing the surgery any differently or any better. You don't want any of the internal contents to spill. Look at this. I'm going to cut this off from here. Again, the calcifications are not as much, but certainly they are there. If I go like this with my hookups, this is what was resting against her chest. And you can imagine if, and I'll briefly talk about it. Again, look at, there's a little bit more fluid on this side. Do your research on this one. And this is true for saline implants, intact saline, intact silicone, textured saline, textured silicone. They always give off this fluid that's right around. And you've seen this on my many other videos. This fluid, if you check it, this is the badness, this is the culprit, and this is your McGann 195 as well. So if you can imagine, this implant is sitting very tightly on the right and also on the left. And then the patient wants to take a nice deep breath. It restricts the movement. The patients have pain going up and down to the neck area. They cannot lift their arm up because it's literally super plastered and super glued, frozen onto the chest, like the breast tissue implant is frozen, so it restricts movement. And this is in itself an indication to basically removing the implants. So there you have it, en bloc resection, the gold standard. The Kahn procedure, if I will summarize, the implants are always returned to the patient intact, or even if they were ruptured, they're always returned to the patient. Capsule, center pathology, rule out BIAL, CL, squamous cell cancer, any abnormal pathology, breast cancer, whatever it may be. Number 3, cultures for aerobic, anaerobic, and fungal. Twilight sedation. No need for a drain. There is so much inflammation, but the way the surgery was done in that right avascular plane and that bloodless plane, such that the need for the drain was not there. This is not the time to be doing a lift, and hopefully she's going to be aesthetically pleased with how she looks. And then overall, pictures are done high definition, showing clear removal of the whole implant capsule. That's the whole purpose and essence of the explant surgery, and that the chest wall showing complete removal of the capsule, and then certainly cutting open of the capsules as you saw. So there you have it. Please share. No implant is safe, and there are many ladies that I've talked to who unfortunately have been living with capsular contracture for years and years, and no one should have to suffer and be in pain, because the relief is very much there, and the certain etiquette that we discussed as to how it needs to be removed. This is Dr. Khan, Executive Plastic Surgery.